Welcome to the third part of Nutrition 2. In the assessment of nutrition, you must use the WHO growth charts, specifically weight for length or height for both boys and girls. Weight for age for both boys and girls, height for age for both genders, and the body mass index for older children. These forms can be seen at the WHO site. The z-score is a child's weight or height minus the median height or weight divided by the standard deviation. This is the table of growth indicators. Please be familiar with this as it will be important when you become doctors. Here is the growth indicators for children 5 to 19 years old. For example, when you are presented with a 4-year-old child who has a height of 105 centimeters and a weight of 16 kilograms, this will be plotted as this. The point of reference is 0, so this would be read as z-score of 0, interpreted as normal. Another example, when you are presented with a 4-year-old boy who has a height of 110 centimeters, weighing 21 kilograms, the mark is between 1 and 2. This should be read as above 1 and not below 2, interpreted as possible risk of overweight. Malnutrition is a spectrum. The left end is undernutrition and the right end is obesity or overweight. Malnutrition types can be primary or secondary. The height for age measures skeletal growth, reflecting the cumulative impact of events affecting nutritional status that results in stunting. This can be a gauge for chronic nutritional status. The weight for height determines if the child has wasting or the child's acute nutritional status. The weight for age has less clinical significance, but it is easier to measure. The mid-upper arm circumference is used in emergency settings and field settings. In 2005, 20% of children less than 5 years old are underweight and 32% are stunted. According to the Sustainable Developmental Goals of the United Nations, for us doctors, we should end hunger, achieve food security and improve nutrition and promote sustainable agriculture and ensure healthy lives and promote well-being for all at all ages. In the ASEAN region, wasting was documented at 5.4 million children and stunting at 17.9 million. Consequences of undernutrition are premature death, irreversible physical and cognitive damage, two-way causality from malnutrition to infections and vice versa, because deficiencies of macro and micronutrients impair the immune system. Reduce lifetime earnings. Key interventions: promoting exclusive breastfeeding, promoting adequate and timely complementary feeding, promoting key hygiene behaviors, providing micronutrient intervention, and fortifying commonly eaten food with micronutrients. For severe acute malnutrition or the protein energy malnutrition, there is inadequate dietary intake of protein and energy. It is almost always accompanied by deficiencies of other nutrients. It can be in the form of marasmus, kwashiorkor, or marasmic kwashiorkor. For marasmus, it is non-edematous malnutrition, failure to gain weight and irritability, followed by weight loss and listlessness until emancipation results. The skin loses its turgor and becomes wrinkled, and loose as subcutaneous fat disappears. There's loss of fat from sucking pads. Infants are often constipated. There is starvation diarrhea. The abdomen may become distended or flat, with intestinal pattern readily visible. Muscles begin to atrophy and there is resultant hypotonia. For kwashiorkor, this is edematous malnutrition. There can be lethargy, apathy, and/or irritability. There is lack of stamina. There can be flabby subcutaneous tissues. There can be liver enlargement, dermatitis as shown in this figure, and sparse hair. Marasmic kwashiorkor has features of both. For example, emancipated with edema. Clinical signs of malnutrition, like presenting with moon fascie for kwashiorkor and semen fascie for marasmus. There can be dry eyes, pale conjunctiva, a beetot spot with periorbital edema. Other signs are as follows. These are other signs. Loose and wrinkled for marasmus, shiny and edematous for kwashiorkor. These are also other signs for malnutrition. In nutritional status and immunity, optimum nutrition is a vital role for healthy immune system. Undernutrition compromises the immune system and makes the child susceptible to infections. Thus, a vicious cycle of undernutrition and infection is established. Studies have shown that diarrhea and other enteric infections can adversely affect growth in children. Repeated diarrheal episodes may also negatively affect catch-up growth in malnourished children. Macronutrients and micronutrients together play a definitive role in the development of the immune system. Essential micronutrients form the crew of diverse immune mechanisms and augment host antimicrobial defenses. Proteins are involved in the development of immune cells as antibodies. Vitamin A and C are important regulators of the immune system, while vitamin E and selenium are essential for protecting immune cells. Similarly, zinc, iron have a complementary role in supporting innate and adaptive immunity. These will be discussed in details in the next part of this online session. For the treatment, there is the stabilization phase, rehabilitation phase, and the follow-up phase. Remember to treat hypoglycemia and hypothermia as well as dehydration on the first week of treatment, then correcting electrolyte imbalances after the rehabilitation phase. Treat infections on the first week. Give micronutrient deficiencies or treat micronutrient deficiencies without iron during the first week of treatment and give iron for the succeeding weeks. Begin feeding or immediate feeding on the first week. Increase feeding for catch-up growth during the rehabilitation phase until the follow-up phase. And stimulate emotional and sensorial behaviors or patterns during all the stages of treatment. Prepare the discharge at the rehabilitation phase. This is the end of part 3.